Welcome to Living Notes podcast Behind the Scenes. My name is Olya and I'm the host of this podcast. Here you will find raw, unfiltered life stories just as they come, amazing, informative interviews from the best of the best experts in different fields, and we're going to talk about everything from beauty to parenting to childbirth to womanhood to clean living to wellness. You name it, we're going to talk about it, I guarantee you. But most importantly, on behind the scenes, you're going to find real stories from real people that live in real world today. Things that happen behind the scenes and that are not seen on social media. We love having you here. Thank you and welcome.
Dr. Stu is a licensed OB/GYN specializing in breech, twin, and feedback deliveries. California law prevents midwives from providing care in these situations. This is exactly where Dr. Stu comes in. A long-time outspoken advocate of a woman's right to informed consent and refusal and the exercise of her free will, Dr. Fischbein is an honorable member of advisory board of the Santa Barbara Birth Center. He previously worked in collaboration with the wonderful licensed midwives at the Sanctuary Birth and Family Wellness Center. He also was a contributor to Your Best Birth, a book published in 2009 and authored by Ricky Lake and Abby Epstein. Since 2010, Dr. Fischbein continues to provide direct patient care and attend home and birth center births with his midwife colleagues. He has also published 2 papers and 1 case report highlighting his experiences and continues to travel and lecture on reteaching breech birth. Dr. Fischbein has made his goal to teach, speak, and write about the normalcy of birth choices, the ethics of respecting women's autonomy in decision-making, and reasonably supported options of selected feedback, breech, twin, vaginal births. I've personally met Dr. Fischbein when my 6th baby happily sat on her bum in a perfect breech position until the very last weeks of pregnancy, and I faced the exact issue of California births. My midwife dropped care because I became a candidate for a C-section. That was never an issue of any of my previous pregnancies because my other babies were not born in California. Long story short, Ellie made her appearance perfectly and naturally in her due time, but the conversations with Dr. Fischbein and knowledge that he shared turned my world upside down in the best way possible, even though I was knowledgeable enough and plenty conscious in my choices. Yeah, because our goal is to, what you said to me was that, I think that the woman should have a birth where she feels most comfortable. For me, it was home. For some, it may be hospital. For somebody, it could be birth centers. So our focus is to help women make the right choices, but make the right choice based on because they're informed and knowing all the nitpicks that come into it, rather than doing it because it's a fear-based mentality, because somebody said so, because everybody says so. 2 of my babies are hospital babies, and then from 3 on, I had them at home. Not initially, I've never even considered home birth because I was always taught that home birth is bad. It's for those weirdos that we don't know who they are, and hospital is the one and only safe place. Well, it turns out, I found out with my 3rd baby, towards the end of the pregnancy, that my doctor, even though he was wonderful and he was pro-natural birth, he could not do what he wanted to do. And he very gently suggested that I move to different care because he did not think that intervention was necessary, but the protocol was saying that unless he does that, he wouldn't be able to practice in the hospital. And so that's when I realized at 35 weeks pregnant with my 3rd baby that my 2 first babies were delivered induced for no other reason but because protocol said so. And that's where I turned to a natural birth, and this is where we want to ensure that women know what they deal with, know all pros and cons, and they're able to make the decisions that they want to make.
Well, one of the things you just said was that they were delivered because protocol said so. And that gets to a whole big issue for me is who are doctors supposedly supposed to represent, and they have a fiduciary and ethical duty to represent the patient, or we call them clients, but the patient they're taking care of. And the problem is there are so many forces on these poor physicians, and even physicians who I don't happen to like very much, or I think are bad or do things that are wrong. Part of it, it's an understanding that they basically, some of them don't know things, but other things, there's so much pressure upon them, whether it be economic pressure, medical legal pressure, peer pressure, time pressure, financial pressure, to do certain things in a certain way and they often use the excuse the hospital won't allow me, or the hospital protocol, or my malpractice insurance won't allow me. And to me, I understand that because we want to continue to live and practice, but to me, it's one of the it shows that they lack one of the rarest of traits, and that's courage. Because courage to stand up for your client puts you at odds very often with your employer or your hospital if you're self-employed. And ultimately, everyone that I know that does what I do, there are a few of us around the country, everyone that I know has the same story. They wanted to do what they did for their clients in the hospital, and either the administration, the risk management, the anesthesia department, the pediatric department, or sometimes even colleagues in their OB department all came down upon them and left them with a choice of either undergoing a peer review process, which was painful, long, and expensive, and may result in their being expelled from the staff anyway, or possibly even if they won that administrative battle, all they would win was the right to stay at a hospital that was going to be hostile and not let them do what they wanted to do anyway, or leave. So everyone that I know that does what I do ended up standing up for what they believed was right, and they ended up having to leave the hospital. And then I don't know a single doctor that's doing home birthing that isn't happier doing it, because they seem a little bit freer to do it. But I understand the dilemma that many physicians who just want to bring home the paycheck, take care of the family, take care of their kids, keep their head down. There's an old Japanese proverb about what do you do with a nail that stands out? And the answer is you pound it back in again. And so anytime, any place, in any corporation or any government or anything, where someone has a point of view that's different, they're going to take heed for it. And it takes extreme courage to stand up for what you believe is right. And our ethical and moral obligation and our fiduciary duty is to our client, not our pocketbook, not our hospital, not our policy. So when a doctor says the hospital won't let me, that gets to this word where women will often say things like, they won't allow me to do this. And that's a big word. When it comes to the obstetric violence world, it's a huge word, that word allowed, because
I've been there. They wouldn't let me go home. With my first one, I came in, and my story was that my very first baby, I knew nothing. I come from Eastern Bloc mentality where doctors are everything. You just listen to them and you follow what they say. And, here I was. It was Christmas, literally, and the doctor was thinking, let's do some the ultrasounds to check how the baby is doing, anti-stress tests, etc., because you're getting towards the end of the pregnancy. And I was like 35 or 34 weeks, and so we started in, and I come in one day and they said, well, there is amniotic fluid here and here and here and here, but we can't really measure it because it's not big enough of a pocket, and the pockets that are big enough are not enough, so we can't let you go home. You're going to have your baby. And I said, well, I need to go home. And they call my doctor. It's a different doctor from my second and third pregnancies. And that doctor, he was on the speakerphone, and literally, they call him, and he says, I'm on vacation. Do not bother me. He picked up, and he was on the speakerphone and said, I'm on vacation. Do not bother me. Call doctor on call and follow the protocol. That's all you need to do. And they call the doctor on call, and doctor on call is, well, I don't know what to do. We are supposed to induce. And they did not let me go home. And I was a young mom. I was 23, and it was my first baby, very wanted, very conscious. It was a couple of years after we got married, and so I didn't know anything. And you're so scared and freaked out. So,
well, when they pull out the injured or dead baby card, you're really, as a parent, you're really screwed, because you're supposed to trust this person has knowledge.
Exactly.
But what this person really does is has fear. All right. And so what doctors do by telling you your fluid is lowish, all right, there are definitions about how low fluid is. And even if the rest of your baby's, what they call biophysical profile, is perfectly fine, there's no reason you couldn't have gone home and thought about it and had a talk with your husband at the time or your partner and decided, you know what, I think we'll wait a couple of days and see what happens. But there's so much fear. From the time that they go to medical school and residency, they're sort of bathed in it. They're, marinated in it. And what happens is when they come out, because there's more fear than confidence, and because confidence doesn't cover you if there's a malpractice or a negligence. Even if there's a bad outcome, even if there's no negligence, a lot of doctors are worried they're going to get sued. And one bad lawsuit can really destroy you. So doctors have this fear, and so instead of keeping the fear inside of them, they project it onto the women of America. And the women of America fear birth in this country, not because birth is something to be feared, but because the professionals that we hire to take care of us fear birth. Mm-hmm. And so they push that anxiety upon you by saying things like telling you that if you go home, so this could happen, or we're going to do an ultrasound on you for no particular reason. Oh, look what we found. Now that your baby is too small, your baby is too big, the fluid is too low. There's this little ditzel on ultrasound or this little thing, and now, I give you a perfect example. When a woman comes in for a structural scan at say 20 weeks, mm-hmm. sometimes there's some little what are called subtle markers for Down syndrome or other things that you might find. If you find one of them, it really doesn't mean anything. And a lot of these women have already had genetic testing anyway, because now we have this thing called non-invasive prenatal testing. It's a blood test at like 10, 11 weeks, and you can do that. So you already know that the baby doesn't have those sort of things. But the doctor will say something like, oh, your baby has a little echogenic focus in the heart. I want to see you back in 6 weeks. Right? So now what happens for the next 6 weeks? Their parents are anxious. Something's wrong with my baby. Yeah, and so they're bathing their baby in neurotransmitters and stuff for 6 weeks that are based on anxiety, which was never needed to be given you in the first place. But a lot of people will project their anxiety onto the pregnant woman to sort of make them feel like they've done everything right. There's a fine line you walk in, and I learned a huge different way to do things when I started to deal with midwives. Because midwives have a whole different way of talking with patients than I learned as a physician. I mean, we never had education in how to talk to a patient. We never had education in breastfeeding or nutrition or any of those things that seem to be important to keep people well. Physicians are experts in diseased pregnancy, but only about 10% of pregnancies, maybe 15, are pregnancies that need attention. The other 85% are normal functions of a woman's body, like breathing or digestion, right? You don't have to think about breathing. You don't see the doctor when you eat your steak dinner, all right? Now, if you have colitis, if you have bronchitis, you need a doctor. But, if you have pregnancy and you develop preeclampsia or preterm labor, a doctor is a great thing to have. But if everything is going normally, a doctor is not always the greatest thing to have, because it leads to interventions, because doctors are trained in that mode of thinking.
What are the essential steps in pregnancy that one can do to ensure the healthiest pregnancy and to prepare for the birth?
I would say that anyone who can find one should always, before they pick their OB, they should interview a midwife. I would just say this. Always interview a midwife. And if you have a choice and you're healthy and you have a choice between a midwife and an OB, not to cut my own throat, but go with a midwife.
And from your, as a doctor and as a doctor who attends births, what do you think a woman should be doing to prepare for the birth? Because birth is a big deal. It's not.
Well, I think they should avoid Dr. Google. I seriously think they should, because if you search airplane in Google, what comes up are the crashes. Right. All right.
Often. That is a great point.
So it's the same sort of thing. If you go to Facebook groups, people who have extraordinary things or terrible things, those are the people that will post on the internet. People with normal lives don't generally post that. My pregnancy was uneventful and I went fine and I had a great time. All right? That you don't see that. So avoid that sort of thing. Find good sources, and midwives and some doctors too will be able to refer you to good websites, to good reads, good books, good videos, good YouTube videos. Happy Healthy Child, Business of Being Born. There's lots of different videos you can read. You can read Ina May's Guide to Childbirth, which is a really nice childbirth book. There's what's it called? I don't want to misname things. We even wrote a book. We wrote a book in 2004, and second edition came out in 2010 called Fearless Pregnancy. And my midwife colleague and my client, we collaborated on this book. It's called The Fearless Pregnancy. I forgot the name of my book. something like parents' pregnancy. Anyway, we wrote it in response to people who were reading What to Expect While You're Expecting. Because What to You Expect While You're Expecting is a very medicalized book. You know, they mean well, but there's always this, it could be this, it might be this, so call your doctor. Almost everything that comes up is call your doctor. So essentially, they're selling a book for $25, and they're dumping all their questions on the physician, on the doctor. Right. But it's a fear-based book because it's in that medical model. So I would tell a woman that just because a physician, a man or woman, has been your gynecologist for 10 years, doesn't necessarily mean that that person is a good person to be delivering your baby. All right? Don't pick, some of us financially we're trapped, and we have to, if we go to like a HMO, like a Kaiser here in California, you get who you get. You can have somebody maybe that you like, or even a midwife to your prenatal care, but you've got a 1 in 8 chance of getting that person when you go into labor. So don't be limited by your insurance. Sometimes it's worth spending a little extra money on getting the birth that you want. A good friend of mine, Bliss Young, she's a student of mine now, she's a midwife. She used to say this time, we used to have a meeting every week with parents, prospective parents, when the sanctuary was still open, which is closed now. But she used to say that there are 2 events in a woman's life that are the most important events, generally speaking. Now, and when we generalize, we talk about that there are always exceptions. But it's their wedding, and it's the birth of her children. Okay. For your wedding, you'll spend thousands of dollars. You'll plan everything out in advance. You'll do all this stuff. For your birth, you take out your Blue Cross card and you say, okay, I'm going to this guy and I have to go to this hospital, and whatever happens, happens. All right. So she poses this question: what if there was such a thing called wedding insurance? And from the time you were 18, you paid $100 a month and went into whatever. And when you got married, all right, your wedding was covered. But you didn't get to pick your dress. You didn't get to pick the venue that you wanted. You didn't get to choose what food you were going to get there. They invited people to your wedding you didn't like. All right? Nobody would do that.
Wow.
Right? But that's what we do with our birth. All right? We spend a lot of money on our wedding. We take our insurance card for our birth. Maybe saving to spend a little bit more on your birth by hiring a midwife, or if you have an OB in your community that does home birthing, or at least finding out from other midwives. And another way to find out who are the good doctors in a hospital is to sometimes call the labor and delivery and ask to speak to the charge nurse or one of the nurses, and ask them, like, who would you go to if you were me? And those nurses just love, first of all, they love to be asked that question, and they love to give advice. And they'll be very honest with you that I wouldn't, I'm thinking of going to this person, what do you think? And, they may say off the record, they may not be able to answer, but if they can answer, they'll be honest with you. And they hesitate, or another way to notice if your doctor doesn't appreciate you asking questions or doesn't give you much time, that's another way to say, maybe this isn't the doctor for me. I know that midwives, their prenatal visits are generally 45 minutes to 60 minutes long. The average OB visit is probably 6 to 10 minutes, if it's even that much. And you can't possibly do preventative care and nutrition and sleep and stress reduction and all the things that help prevent things like preterm labor or hypertension or other things in 6 to 10 minutes that you can do in an hour. Plus, you develop a strong relationship with your midwife. So feeling confident and safe is a great thing for birth, because I'm rambling here, but safety is a really important thing for birth. And if you think of how other mammals give birth, your dog, a deer, a hippopotamus for that matter, okay? Mammalian birth should be quiet, safe, and alone, all right? Those 3 things are the opposite. Well, safe is relative, but quiet and alone are not what you're going to get at a hospital. Right? When a mammal goes into labor, she goes off by herself. The other mammals leave her alone. If she's hungry, she eats, or if she's thirsty, she drinks. If she's uncomfortable, she paces, or she lies down, or she stands up. When she's ready to give birth, the baby falls into the dirt, or the cat litter, or the hay, or the carpet, or wherever it is, and nobody rushes in to cut the cord. Nobody ever separates the baby from the mother. That's how mammalian birth normally works. And if a predator approaches while they're in labor, or if little kids run in the room, or a mammal is anxious or nervous, labor stops because they put out adrenaline, adrenaline stops labor, and off they go to run away to find a new place, and then they only go back into labor when it's safe. And this way, nature ensures that the best possible chance for the offspring.
I would support every word because I had exact that.
And everything that we do to the human female is antithetical in the hospital model to what I just described. You make them get in your car and drive to the hospital. To change into a hospital gown and pee in a cup and lay strapped down in bed with belts on them and sign documents about surgery and potentially death or power of attorney.
Right, the documents that nobody reads because the last thing that I want to read is when I'm having contractions.
Every 3 minutes you're contracting. And then they ask you silly questions about, like, what did your grandmother die from and how many stairs do you have in your house, which are not really relevant to the fact that you're panting and surging every 3 minutes. And then, then they don't let you eat anything. You can have ice chips or a popsicle. And then also they put you in a room on a monitor, and then you have your mother-in-law, your husband, your partner, or whatever, and your Aunt Betty sitting in chairs, and they're all staring at you. All right? Okay? And then we wonder why labor is dysfunctional. We wonder why they were every 3 minutes at home, and by the time you get out of triage in the hospital, your contractions are 8 minutes apart. And then you're already at the hospital now, and your contractions have spaced out, so what do? They speed them up. They augment you, or they rupture your membrane. They do something to intervene because now you're there. And since you're there, we can't possibly have you sitting around taking forever because we need the rooms and we need to keep things moving. And so that's the whole cascade of interventions gets into play because what has happened is that the medical model has forgotten the normalcy of mammalian birth. And they forgot that human females are also mammals. And they have the same exact mechanisms in their primitive brain, their pituitary, and all that stuff that mammals do. And when they're anxious, labor doesn't go well, and hospitals are places of anxiety. Most people experience in a hospital is not good. Everybody loves their baby, and everybody loves that. They can't wait to have their baby, but maybe I get a skewed population because I get people who are coming for second opinions and stuff. But not a lot of people have great memory of the time that they were in the hospital.
There are some, and the good thing is that they are surfacing more and more now. But unfortunately, yes, they are limited by the law. Many laws that for example, I had a friend who just had a baby a year ago, and she had a water birth at the hospital with the midwife. And she went in for a second baby, and she can't have a water birth anymore. They changed that policy, so she now can labor in the tub, but she has to have her baby. And she was just distraught because I had water birth, and I know once you get in, there's no getting out. I mean, it's a different experience. But what I do want to touch on, and you touched on it while you were talking, but I want to dive in a little bit deeper into this. A birth that a woman wants versus a birth that is best for the woman and the baby. Because what I want to avoid, because I get so many moms who are so obsessed with having a natural birth, and I think natural birth is the most important thing. That's how I found you, because I felt like there's no reason for me to have a C-section with a sixth baby when everything went perfectly healthy, and the only thing is that she's sitting on her bum at 38 weeks, which she turned. When you came when we met, she was already had down. But I wouldn't have that luxury in the hospital because they would C-section me prior to that time on my pregnancy. But at the same time, there are women who are so obsessed with having a no C-section that they will go any lengths to get this natural birth because it is a trend too right now.
Yeah.
So there is the negative side of it. So how does one understand and to prevent from these extremes?
Well, you can't necessarily prevent extremes, but what you can do is you can take the time to give every woman what I would call reasonable informed consent. There's no such thing as true informed consent because you can't talk about every possibility of every choice that you make. But you need to give people informed consent. And if I see a woman and I give her, and everybody has a bias, and you're supposed to try to suppress your bias, but it's not humanly possible for a doctor who doesn't do breaches to suppress his bias against breaches. And for me who does do breaches to sort of suppress my bias toward breaches. But you want to give people honest, informed consent. And if you give people informed consent, medical ethics and the Code of Ethics dictates that two people given the same information should not be presumed to come to the same conclusion, because everybody has different life experiences. And there are people who come who were born at home, who've seen their siblings born at home, and they know that home birth is fine. And then there are people who don't want to experience one contraction. They'd be more than happy, even if they're told that having an elective C-section at 39 weeks prior to labor with no contractions, here's the benefits of that, but here's also the risks for this baby and you and maybe future babies down the road, because now you have a scar on your uterus. How many babies do you, given the information, how many babies do you want, what sort of thing. And if they choose, after giving all that information, to say, I want a C-section because I don't want any pain, then that's a reasonable choice for that person. Mm-hmm. And we would never tell them otherwise. We just, because it's not our job to skew people or funnel them or by any means of coercion to make people do something that they don't want to do. And just as much as, as a tenet of healthcare is giving informed consent, is the right of informed refusal. So a woman can be given information and say, okay, I understand all that, but I still I don't want this done to me.
Are they even able to do that?
What's that?
Are they able to do that in the hospital?
They don't know they are, but everyone has the right to do that. Hospitals do not have the right to force you on it. Now, they have the ability to say to you, well, if you don't do what we say, we're going to call Child Protective Services.
Exactly.
And that is coercion. And even though ACOG, the American College of OBGYN, has a really brilliant statement against coercion out, it doesn't stop people from doing that sort of thing. Mm-hmm. And along with the right of informed refusal is also something that no one ever talks about, and that's the right of uninformed refusal. All right? If somebody doesn't even want to hear the things and just say no, no means no. Mm-hmm. If it means no in every aspect of our lives other than birth, it certainly means no in birth. You can't, if a woman is zealous about having a natural childbirth, all right, all you can do is say, listen, your blood pressure is 160 over 110, you're not a good candidate for waiting any longer. This baby needs to come out, you need to be induced. You need to go to the hospital.
So what are the markers? So that the women who are reasonable, who can understand, where are the markers where she can trust the doctor? Because someone comes and say, well, the doctor said, I have heard those stories.
Yep.
The doctor said, my blood pressure is so much, but I'm going to go home, I'm going to drink some tea, and I'm just going to have the baby naturally. So what are the markers that they were?
Well, if that's her choice, that's her choice. And if she, and sometimes she'll be right, and sometimes she'll be, dead wrong.
They know?
Well, another thing that they can always do when you're not liking what you're hearing from your practitioner is a classic thing that you should get, whether it's in law or about your car or anything else, called a second opinion. Mm-hmm. And you should go get a second opinion, and generally from someone who will not be involved in your care beyond giving you the opinion. Because the problem is, people who give second opinions often skew their opinion to sort of get you to switch to them or do something different. You shouldn't do that. So if you're being told by your doctor that your blood pressure's up and that you really should be induced, and you say, no, I'm going to go drink some tea, and I'm not, I'll be back in 3 days, I'll come back and you can do another biophysical profile on me, all right? And the doctor says, I really don't think that's smart. The doctor should say, listen, would you reconsider getting a second opinion from an independent person? And if that's not going to change their mind, then there's no point in doing it. But sometimes, again, that's where trust comes in, and that's why the relationship with a midwife or your own doctor, if you've been with that doctor for a really long time, and the doctor spends time talking to you, it's very rare, Olya, for us to see a patient where they know us well enough and we give them advice and they say no. All right? Because we have developed a really trusting relationship with them.
Trusting relationships is big because, to understand who you're seeing, a person who at least knows your name.
Yeah.
So my first doctor, he was talking to me about some issues, and I said, wait a second, we don't know how this happened last visit. He's like, what's your name? This? Oh, my name is different, and I was 32 weeks pregnant.
Oh, he had the wrong chart.
The wrong chart.
Oh,
so
But getting back to your story where you were at the hospital and you called your doctor and he said, I'm on vacation. Listen to the other doctor. Okay. That's a problem when you're in a system where there's random call or what we call doc in the box or a rotation where, you might finally get a doctor or a nurse that you really like. Mm-hmm. But guess what? It's now 7 o'clock in the morning and they're off shift.
And
now you get somebody else. Right? I know that for lifestyle sake that there's a high burnout rate for those of us that do what we do 24/7. but ultimately OB should not be like, a service industry where you work a shift, because it's a very personable thing. Again, it gets back to, ER is different. You break your nose or you have an appendicitis, you go to the ER, you get whoever you're on, fine, they take care of you, you never see them again. But there's something much more personal about pregnancy and childbearing, and it's not something that's I think shift medicine serves well. It serves the doctors well because it is really hard to be on call 24/7 for your clients all the time, especially in a busy practice where financial remuneration is not that great, so you have to do fairly large volume in order to make a living, and your malpractice premiums are high, and you have 3 kids at home and a wife or a husband. I'm sorry, I'm a traditionalist. I'm 62 years old, so I say dumb things sometimes. Forgive me, but it could be a partner, it could be whatever your spouse is, and you have other demands being put on you. Like, honey, you're never home. You're missing out. So it's really easy. And currently now, when doctors come out of residency, they don't expect to just start their own practice anymore. They essentially are looking for a job, guaranteed hours, know what call nights they're on, and when they're off, they don't carry a pager. I've been carrying a pager now for 33 years. And even when I'm in Europe, I still respond to WhatsApp or whatever text from clients who have questions.
I wasn't even your client and you responded, so I second that. So,
Yeah, another rule for helping women to determine what to do is something that there's much too little of these days, and that's common sense. If you're being told something that just doesn't sound right, that just sounds a little weird, then check into it. Look it up. Unless the baby's heart rate is down at 80 or something like that, there's never a situation where you can't say, listen, I need a couple hours to think about it. All right, I need, the doctor says, I think you need to go to the hospital now because your fluid is low. And you say, well, is my baby's heart rate okay? Yes. Is my baby otherwise okay? Yes. Then I'm going to take some time, whether it's a few hours or tonight or tomorrow, and I'm going to go home and look at some other options and think about it, and I will get back to you tomorrow and let you know what my decision is. You have that time, you have that right to think about it. Now, some doctors will skew their counseling to tell you that the emergency that you have is really an emergency, or the situation you have is really an emergency when it's really not an emergency. Okay.
Let's talk about the breech too, because in my previous, so that was my baby number 6. First 2 were hospital babies, so by between baby 3, 4, and 5, majority of them sat on their bums until the very end. But it was never an issue. My midwife was confident that, one, she's like, well, they will turn, but if they won't, there was a certain protocol for the breech delivery. She was educating me on what it is, because it was allowed. It was legal, and so it was not ever really an issue for me until I came to California, and here the breech birth is considered to be a C-section only. And in my few days that we were frantically trying to figure out what to do, as we were researching it, everybody said, hospital C-section, those are your only options. You cannot deliver your baby, or it's unassisted. Unassisted birth is not something I wanted to have. Even though it was my 6th baby, I still felt like I wanted somebody who I can trust, who I can put my worries into. Me, my midwife is a person who, and my husband can support that. When I am in birth, I don't want to be touched. Exactly what you said. I don't want to be touched. I don't want to be moved. I need my quiet space where I can just be in my zone and zone out from everything, be in my own little universe, and then have the baby. But I do want to know that there is someone out there who is kind of guarding and watching and knowing that if something is off, they will see that and they will know that something is off, and they will alert me, and we will have a safe, as much as it's possible. Nothing is 100%, neither in the hospital, nor at home, nor anywhere in the world, to say the truth. So that is where the midwife's coming for me. So breech birth. Let's talk about it.
Well,
Dangerous.
I give a whole day and a half seminar on this topic, but I'll try to sum up for you.
We'll link your seminar.
I'll tell you
as well.
First of all, my name of the book is Fearless Pregnancy: Wisdom and Reassurance from a Doctor, a Midwife, and a Mom. It just popped into my head, so I had to correct that. But can't believe I didn't remember the title of my own book. nonetheless, breech. There's much misconception about breech out there, and there's much fear that's unfounded surrounding breech delivery. And the breech story is a very interesting story because up until about the 1950s, breech was just considered a variation of normal. And then there became some papers, began to come out in the 50s, 60s, 70s, that said that maybe breech births were better off being born by cesarean section. Many of these studies, many of these things were retrospective. There was really not looking carefully at patient selection, planned or unplanned breeches, anomalous or normal fetuses, term or preterm, skill of the practitioner were never considered. It was just, sort of an outcomes-based, retrospective, chart review or birth certificate review. And data was sort of leaning toward cesarean section. So the rate of cesarean section for breech began to rise in the 50s and 60s. And then there were some articles in the 70s and 80s that came out that supported properly selected term breech delivery. So there was this question out there. And so somebody said, let's get one study, let's do a large study to see what the answer is. And even though it wasn't that large, there was a paper that came out in 2000 called the Term Breech Trial, which found that babies born by cesarean section did better with morbidity and mortality than babies born vaginally. And so this sort of fit the model by which many countries and doctors wanted to practice. And so it was immediately adopted before it was ever actually looked at critically. And in order to look at a study critically, you actually have to look at the material and methods section, and you can't just read the abstract, and you can't just read the conclusion, all right? Because the material and methods section is the heart and soul of any paper. Because sometimes people will come out with a headline that says, this thing happened, and then you look and the study was like 12 people, all right? So you have to look at these things. And their numbers were high, but there were a lot of flaws in the study, and within 2 years, even though that paper came out and residencies across the Western world began pulling breeches and nobody was teaching breech anymore, within 6 months, gone. 97% of the centers that were participating in the term breech trial, there were 126 centers, and 97% of them that were doing breech delivery prior to the trial stopped doing it because of the trial. All right. Yet within 2 years, they found that the data was flawed, very flawed, and that the outcomes for babies were really no different. Since that time, there have probably been 10 or 15 decent studies who have looked prospectively, retrospectively, and they found data that was the only study that's an outlier was the term breech trial. Everything else shows that vaginal breech cesarean birth not significantly different in morbidity or mortality, but the damage had been done. Mm-hmm. And there are still many physicians I still see, because I do a lot of consults for breech. Many physicians, patients will come to me and say, my doctor gave me this paper, what do you think? And it's the term breech trial. It's 19 years old now. It is the only outlier, and yet it's still the paper that's quoted by physicians. Now, it's not wrong for a physician to tell a woman that I don't know how to do a breech delivery, therefore, if you're going to stay with me, you should have a cesarean section. Because that makes sense. Mm-hmm. And no doctor who doesn't know how to do a breech delivery should ever be put in the situation of a woman saying, you must do my breech delivery.
Of course not.
Because that's not fair to the physician.
Yeah, of course.
So ultimately, what would be the ethical thing to do is for a physician who doesn't do breech delivery at term, we're not talking about premature babies, we're talking about term, is to say to them, I don't know how to do breech delivery, but there's a doctor in Linwood, or there's a doctor in San Francisco, or a doctor in wherever who does breech delivery. Why don't you go have a consult with him or her, and then come back, and we'll have a conversation, and we'll talk about it. All right? That would be ethical. That would be totally ethical. That would be beautiful to offer that choice to a woman. But that's really not what happens. Breech birth, head gets stuck, baby suffocates, stupid idea. Mm-hmm. All right? But that's not true. If you properly select your breech births, and there are certain criteria that every doctor is slightly different who does breech birth, but they're all generally the same. It's about, weight, position of the feet, flexed head, term, no anomalies, normal pelvis in the mother, that sort of thing. If you select those people properly, then I have found, and other researchers have found, that breech birth succeeds or does not for the same reason that head-down babies succeed or not. Mm-hmm. Sometimes labor peters out. Sometimes labor stalls at 7 centimeters. Sometimes they push for a couple hours and nothing happens. But it's not because the foot comes down or the cord comes down or the head gets stuck. But the visualization of that happening freaks people out. Mm-hmm. And so if a doctor tells you that it's dangerous, that seed is already planted. How do you get rid of that seed? It's really hard to do.
No, but
And that's the word in the general community, is that breech birth is dangerous. That's inappropriate. It's not true. All right. Breech birth is rare. Breech birth can be difficult, and breech birth can rarely be dangerous. Okay. But the truth is that the same could be said for head down babies. All right. Head down babies could be difficult sometimes. They could be rarely dangerous. So you could substitute anything you want in there. Birth is inherently has some risks to it. Once the sperm and egg meet, then there's the potential for problems all along. And if hospitals were so perfect, all right, why would we be having NICUs filled with babies in the hospital? All right, we have bad outcomes at home, and we have bad outcomes in the hospital. We have great outcomes at home, and there are great outcomes in the hospital. All right, one isn't necessarily worse or better than the other. What is important is for women to understand the pros and cons of both choices, and then be able to be given the freedom to make an informed decision that best suits with her and her partner's desires, and also her life story. All right.
You answered my last question a little bit already, but I'm going to ask anyway. So
I've done this before.
As a doctor who attends home births and outside of the hospital births, which are birthing centers, etc., what do you think on safety of the home birth particular? Because birthing centers, many people feel like, well, it's almost like a hospital, but with the home privileges. But what about the home birth?
Well, ultimately, in the home birth, you're farther away from an operating room. There's no question about that. But the likelihood of something happening suddenly, like might happen in the hospital, is very, very rare to happen at home, because we're not messing with Mother Nature. Okay, we're not starving you, we're not immobilizing you, we're not augmenting you, we're not overstimulating your uterus, we're not taxing the baby, we're not doing the things, multiple vaginal exams, the risk of infection is much less. We don't see those things at home because of the way home birth is dealt with. Plus, to be fair, we're cherry picking our clients. We're starting with healthy women at term. We're not dealing with preeclamptics, we're not dealing with preterm labor, we're not dealing with malformed fetuses. We're not dealing with those problems.
And those should be addressed into the hospital, because
Having said that, though, safety is a relative term, because if you think the default position is the hospital is safe, then I have a bridge in Brooklyn I can sell you, okay? Because many of the things that are done in the hospital lead to less safety. Closer to an operating room, more likely to need it, but it's less necessarily safe for the baby. And I'll give you some examples, okay? In 1970 in the United States, the C-section rate was 5%. Now it's 32%, all right? That's a 500% increase in the cesarean section rate.
Which is insane.
If, however, we had a concordant drop in cerebral palsy, or neonatal death, or maternal death for that matter, then maybe you could say there's some benefit from that rising C-section rate. The sad part is that the cerebral palsy rate is about the same, the neonatal death rate is about the same, and the maternal death rate is actually higher, because there's more risk from surgical birth than there is from vaginal birth to the mother. So we have a 500% increase in the cesarean section rate with nothing to show for it, right? Why did that happen? There are many reasons why it happened, but the main two reasons in my book, in my head, are the advent of continuous fetal monitoring, which is the belts, which was supposed to eliminate cerebral palsy, because now we'll catch things early, all right? All it's led to is rapid, two knee-jerk C-section, knee-jerk interventions for things that might be normal. And the other thing was something called the Fischbein curve, which is where, when I was an intern and a resident, we had to chart every hour to 2 hours. We had to do a vaginal exam on everyone in labor, so we could put a little X on the chart, and we could follow their progress, so it made sure that they were going along the curve for primips, which are first-time moms, or multips, which are women who've had more than one kid. And if they weren't, then we were supposed to intervene. We were supposed to break their bag of waters. We were supposed to start Pitocin, start to do something, all right? Because this is the mentality that all labors must go exactly the same. But we all know that that's not the case. Everybody knows that. So again, it gets back to common sense. Why are we doing these things, all right? Nature's evolved this system for tens of thousands of years. And yes, we've invented penicillin and sterile surgical techniques, and we've done great things with the advancement of medicine. But not everything needs to be dealt with. One of the greatest arts in medicine that's never taught is the art of doing nothing. All right, we don't learn that anymore. So anyway, so we get to the point where where safety is defined by the hospital standard, right? But if you're having 32% of women who walk into a hospital get a cesarean section, right? That's not necessarily safe. And if you're not feeding them, and if you're augmenting them, and you're taking babies and you're cutting the cord quickly and you're separating baby from mom and taking the baby eventually to the nursery, why does the baby ever need to leave the mother? What other mammal baby ever leaves the mother? All right? Oh, well, we have to do these, we have to wash the baby. Well, why do you have to wash the baby? These are things that Thomas Paine from the American Revolution has a quote. In my lectures, I like to use a lot of quotes because there's a lot of wisdom in history. Not necessarily a lot of wisdom. Knowledge and wisdom are two different things. There's a lot of knowledge now, but there's not necessarily a lot of wisdom. And he said something like, the long habit of not thinking something wrong gives it the superficial appearance of being right. So why is it that we immediately cut the cord? Why is it that the baby would be shown to the mother and then handed to the nurse and taken over to the warmer? Why is it that we used to prep a woman's vulva with iodine before a vaginal birth? All right? Why do we do those things? Because that's how they're always done, because they're thinking of it as surgery. But it's not surgery. Now we know that mother's bacteria are really important for the baby. So why are we washing the mother's bottom off? All right? Because we have a thing for hygiene, but that's not part of nature. It's not designed that way. Do you wash your cat's bottom off? You wash the horse's bottom off? No, you don't do that sort of thing. You let nature be nature. So hospitals don't allow these sorts of things, so that necessarily may interfere with safety. All right? Yes, they're closer to an operating room, but yes, they're far more likely to need an operating room simply because of the things that they're doing. And again, I don't consider myself a cowboy. I don't want to do something that's going to put a woman at risk, her baby at risk, her partner's family at risk, or my career at risk. I do these things because I was partially because I was trained to do them. They weren't considered abnormal when I was in training, as they are now. And the hospitals weren't letting me do them. And I wanted to offer women a choice, right? It would be much easier to conform. It would be much easier to just do what the hospital says and blame the hospital when I'm violating my ethical code, all right? And these are not bad people. I mean, again, I'm not saying the administrators of a hospital or the doctors at a hospital go home every night and say, honey, guess what? I did 5 unnecessary C-sections today. Let's go have dinner. No, they don't do that, all right? They come home and they think they've done good because the alternative is unthinkable, that they actually think they're doing wrong and they're doing it anyway. So they have to rationalize it, and that gets us to a whole other off topic of something called cognitive dissonance, which your listeners probably will know what that means, but it's essentially cherry picking the data that supports you, ignoring the data that doesn't support you, or ridiculing people who have a point of view that's contrary to your comfort zone. Because no one likes to have dissonant cognitions. Cognitions are just thoughts. It's like, I like ice cream, I'm fat. All right? That's cognitive dissonance. You've got to find a way to solve that. So you say, okay, I'll have ice cream today, I'll start my diet tomorrow. All right? I figured out how to solve that. All right? But when it comes to bigger issues, all right, people have to do this. We see it in politics every day. We see it in business every day, that people will deny the obvious because it makes them uncomfortable. And that's what's going on a lot of times in the hospital setting. And that's why it's really hard to put the word safety into a box and say which is safer. All right? Again, it's a personal decision. If you lived your whole life with people dying in your house and people being born in your house, because we've sterilized birth and we've sterilized death as well. People don't ever see people die anymore hardly, because they'll die in a nursing home, they'll die in a hospice. And that's when people used to die in the home. People were born in 1920, 99% of people died at home and 99% of people were born at home. And in 100 years, it's kind of exactly the opposite. It's almost reversed itself 100%. So if that's the family you grew up in, you're homeschooled and all that sort of thing, home birth to you is a normal thing. But if you grew up in a family that, that was traditional, everyone in your family are doctors or whatever, and they're traditionalists, stuff like that, and you want to have a home birth, a lot of them are going to tell you you're nuts. So you have to decide what works for you, what outside pressures you want to deal with, and there is no right answer, because there is no guarantee that any place you go is safe. Some people will feel safer at home. Some people will safer in the hospital. It's too bad a hospital can't just let you come in and then leave you alone. All right? Even though I'm still a fan of home birthing, because I think even getting in the car and driving someplace disrupts the mammalian model of birth. That's why I like home birth better than birthing center birth. But ultimately, if the hospital would let you just be yourself, all right, then the hospital would be a great place, because then you have an operating room, 50 feet down the hall. But the chance of you needing it is going to be less. But the hospitals can't do that simply by the way America is designed now, with the liability and legal aspects and administrative people that have to administrate. They have to come up with things, like hand washing seminars and diversity seminars and sexual harassment seminars. These are the things that hospitals are taking important now, as opposed to nutrition and breastfeeding and bonding and. And again, and the last thing I'll say about the midwife, because I'll go full circle here. I think midwives look at mother-baby as a unit, and that's the way it should be, because they are a unit. Whether they're still pregnant or whether the baby's out, they're a unit. They need each other. Doctors are not trained that way. We're trained as a pregnant woman. Once the baby's out, the baby belongs to the pediatric department, and it doesn't belong to the obstetric department anymore. And I have no say over the baby.
My second one was delivered because there's too many risks according to perinatology. And I said, we just don't want to deal with it. Let the pediatricians deal with it and neonatologists deal with it. Literally.
Yeah.
That is why my second baby was delivered, because they said, well, this way you're not our patient anymore. End of conversation.
Yeah. So, safety is relative. All right? Whatever you feel is safest, once you're given information, that's the choice that should be honored. It should be respected.
So make your choice, and then let your partner deal with the outside pressure.
Yeah, hire a doula. I mean, first-time mothers, boy, we didn't even talk about that. We can't get into every topic, but I would say for first-time mothers, for absolutely certain, you hire a doula. You've got. I don't know what the percentage is. I can't remember, because I screw up my percentages in my head. There's so many. But if you're hiring a doula, there's so much less likely you'll need intervention or pain relief when you have a doula.
Somebody who will watch back.
And by the way, you're a perfect example, because there is a paper that came out that said for people that have an unnecessary ultrasound in the last month of pregnancy, I think they have a 22% higher cesarean section rate.
Mm-hmm.
Simply because if you do an unnecessary ultrasound, they'll find something. Like the fluid will be lowish. So we'll have you come back in 3 days and we'll check it again. And now you've started planting the seeds of anxiety and doubt, and induction comes into play and all those sorts of things. So, technically speaking, avoid interventions unless they're absolutely necessary. And if you're not sure they're necessary, then seek a second opinion.
Thank you.
And hire a midwife.
Thank you, Dr. Fischbein.
You're welcome.
It was a pleasure.
You're welcome.
Thank you for tuning in. You can find Living Notes on Instagram @livingnotes and on the web at www.living-notes.com.